If my doctor says I'm low risk, I have nothing to worry about. False, false, false. X. Get that out of there. If the doctor says I'm low risk, I have nothing to worry about. That's the same thing like my doctor says my labs are normal. We already talked about that. Like, get that out of there. Like, that is not true. All right, welcome to another episode. Yours truly, Dr. Barry Pierre. And remember, we are in our mini series of what medicine has gotten wrong with our patients, right? And today's a good episode. Today, we're going to talk about the doctors who will kind of ascribe a person as a low-risk patient, right? Some of you may have been classified as a low-risk patient or had a family member classified as a low-risk patient, only to have something happen to them in like 3 to 6 months, right? And you're trying to figure out, if I was a low risk, how did the thing still happen? And it's an important question. And I think it's one of this episode is more to try to get back into our psyche of the provider. So when patients are hearing these things, they can kind of figure out, like, all right, this is what the doctor was thinking, but this is a question I should be asking, right? Because I think that's important, right? Because a lot of times as a provider, we'll have our thoughts and our game plan of what we're going to do for our patient. And then our patient asks a question or two or voices a concern, and we're like, you know what? I like that. And let me go a different direction, right? So that's, I think, the point we're talking about today. And this study found that 1 in 5 low-risk patients experience a health risk event within a year, right? 1 in 5, right? That's a lot, right? That's a lot. And how does that happen? Like, was it a failure? That's probably the better question. Like, did somebody drop the ball, right? Did somebody drop the ball and this low-risk patient, maybe you're a person who gets an annual physical once a year because your doctor says your labs are great, right? And we already talked about why your labs are great doesn't mean everything is great. First, obviously, we want you to do, right? You know, I wouldn't be me, right? If I did it, do what I need to do here, pay some bills. I need you to like and subscribe to the episode. Let us know how you're feeling about the series, the channel, whatever question you may have. Drop it in the comments, but make sure you like, subscribe, and send this out to about 10 people, right? Like, that's what we need you to do here, right? And this is another question that if you have, right, have you had someone, I got my questions down. Have you had someone, that felt fine at the doctor's visit only to have a major health scare, later on, like within, 6 months or something? Drop it in the comments. Let us know, right? And at the end of this video, you're going to figure out how to spot some of the hidden signs within your own risk assessment to ask the right questions, right? We want to get you asking the right questions. Because again, I remember, I think I was a resident. I was taking care of a patient who said that, you know what? I just had my annual physical like last week, right? Last week, everything was good. And the patient was in the hospital because they had a heart attack, right? It was a 50-year-old guy, right? Great. He said it was a great physical. He does his medication. He takes his medication like he's supposed to. And a week later, he was in the hospital because he had a heart attack, right? Again, no one dropped the ball there. Just sometimes, even when everything looks good, right, there's still some questions you want to make sure you get to the bottom of it, right? So that's what we're going to talk about today. We're going to talk about the mindset of the doctor who says, you know what, you're a low risk patient, and how there could be some dangers behind that. All right, so before we start, right, especially with this kind of discussion, I think a lot of times we have to be honest with ourselves, right? We have to be honest with ourselves in medicine, and for the patients, right? More importantly, for the patients, y'all don't want to hear bad news. Like, no one wants to hear that they have bad news. No one wants to go to the doctor's office with the anticipation that they may hear some bad news, right? So it is by default that your doctor wants to tell you that everything is good, right? Your doctor wants to tell you that. In fact, we feel bad when something comes up and we have to tell you that, all right, it's not all good. I remember I think it was one of my first few patients when I was in outpatient medicine. Hadn't seen a doctor in years, right? And of course, that means they were perfectly healthy. No, they were on no medication, so they said they had no medical problems. So I said, oh, okay, cool, but I did my due diligence, right, like I always do. And after doing the blood work and doing the testing, come to find out, not only is this person not just fine, they got cholesterol issues, diabetes issues, kidney issues. So all of a sudden they were coming to me, right? They hadn't seen a doctor in years, just want to get a quick little checkup. And now I'm having to be the bearer of bad news and say, hey, guess what? Your clean bill of health wasn't so clean. And now you have high blood pressure, diabetes, kidney problems, and I got to send you to a kidney specialist because you might be on dialysis if I don't do anything. All right. So clearly that wasn't the visit that they were anticipating, not the visit that I was anticipating. So that's where, when we think about the mindset of the patient and the doctor, no one wants to be the bearer of bad news. So it's always in both people's best interest when they can say everything looks good, right? Which is why they would tell you, like, all right, yep, you look good, your labs look good, you're fine. Like, you see me in a year, right? And a lot of times that's the case. A lot of times you are fine. A lot of times there is no issues. But there is the small caveat times where there could be a problem that, as an advocate for yourself, you have to be able to say, I hear you say that my blood work is fine, but I want to get to the bottom of it a little bit more. I want to do a little extra. I just want to make sure, right? And again, at the end of the day, remember, it's your life. It's not your doctor's life, right? It's not your nurse practitioner's life, not your PA's life. It's your life, right? Life equals health, right? So if you can do some extra, right? If you can advocate for yourself to get some extra things going, right? To ensure, right, that your life equals a longer and better life and more health, right? Again, I'm not here to argue against that. So we're going to talk about today, like, what are some of the risk assessment issues that occur, right? Especially when we talk about medicine. Medicine is very guideline driven, very checklist driven, and insurance driven too, right? I got to say it. A lot of these checklists, these guidelines are insurance driven. So yeah, we may want to do some extra things, but we recognize doing these extra things, guess what? It's not really helpful for both parties. And more importantly, insurance doesn't cover it. Or more importantly, your insurance is telling us, hey, I'm not going to do that test, or I'm not going to pay for that test because they're not of certain age, right? Going back to the guidelines and checklists, right? So a lot of times the physician decision-making is kind of handcuffed because of these constraints that are just outside of themselves, right? But again, that doesn't mean that you can't advocate. It just means that is the box that your physician is kind of walking in. And sometimes they just need more information, right? They need more advocacy from yourself to figure out, like, okay, all right, yep. Like, my patient told me that they had a family history of this, so this is why I'm ordering this, and this is why you insurance company are about to pay for it, right? This is kind of the name of the game that goes on, especially when we talk about getting our health together, right? Because again, everyone could be a low risk patient. You could be a patient, everything looks good, your labs look good, your vitals look good. But if there's something that you can kind of add to that pot that can sweeten the deal, that makes me go the extra mile, right? We will do it for you, right? But sometimes, again, it's this kind of back and forth, right? So again, it's not your doctor dropped the ball, right? I don't want y'all to go running and trying to sue your doctor, right? Like, I've been sued before. Your doctor didn't drop the ball. A lot of times it's this personal advocacy that has to happen within yourself, right? To make sure you get to where you need to get to. So let's talk about, this aspect of, what I think, right? What I think is important, especially when we talk about advocating for yourself, right? As a provider, we have to recognize that these guidelines, these checklists, they're typically based on certain populations, but it's not concrete. It doesn't mean that if you fall within this category, you are 100% okay. We know that. Like, the patient who saw me in the ER a week after the physical, he recognized that, right? So we have to understand that these are an assessment, but this is just a part of our tool belt, right? Like, all right, boom, I use this assessment to say this isn't going to occur. A very common thing in the hospital, we have this thing called the D-dimer test. And if you never had a D-dimer test, good. But if you had to have it, right, like, it's one of these tests where it's very sensitive but not specific. What does that mean, Dr. Pierre? So typically when we're thinking about a D-dimer, we're concerned that a person may have a blood clot. And we know that patients with certain clinical criteria, going back to our guidelines and our checklists, if their D-dimer is high, it's an increased risk of having a blood clot. So guess what? Guess what I can do? I can order a certain test. But I can't order that certain test, right? Or I shouldn't be ordering that certain test if the D dimer is negative or within normal limits, right? So it's one of those things where, like, it doesn't necessarily tell me that yes, you have a blood clot, but it gives me a higher suspicion that you may have a blood clot, if you understand my drift, right? So just so we can kind of get to where we get to. So understand that these checklists, these guidelines, they have their limits. And one thing I always tell, especially the new physicians, when I was a program director, is you do have to trust your instincts, right? And this is for you and the patient, right? Trust your instincts, right? If the tests aren't give you the response that you need to get to, maybe they're the wrong tests, right? Maybe you need to go deep and down further, right? So understand that if you have a sinking feeling, right? And especially I tell patients all the time, remember, your body's your body. If you have a feeling that's, something's different, I don't know, something's off, you have to be your number one advocate in recognizing that, because sometimes the tests can be within normal limits, right? Again, go to the first episode in the series. Sometimes your normal labs can fool you. I like this big one, right? Building a symptom diary, right? Like, that's such a big one, right? And again, I talk about having a checklist, having a preparation before you go to the doctor's office, having a list of symptoms leading up to the doctor's appointment would be so key, because maybe you forget that, like, oh, and then one time when I vomited, it projectile, right? Like, there's some things you may forget to, like, include, that once your doctor knows, like, oh, that happened that one day. Oh, I may have to go a different direction, right? So again, this is where that advocacy comes in. Ask for the why not list, right? When your doctor says, I don't think it's a heart attack, make sure your doctor can clarify why they don't. Make sure your doctor can clarify why they don't think it's a heart attack, y'all. Like, I think that's self-explanatory, right? What do you think, right? If your doctor can clarify why they don't think something is the thing, right, and with great confidence, like, you're going to feel more confident that it's not the thing. But if you say, hey, Dr. Pierre, I think I have testicular cancer, right? Or breast cancer, or I think I'm having a heart attack. If I can't really clarify why you're not having a heart attack, guess what? You're going to think you're having a heart attack. You're going to think you're having testicular cancer or breast. You're going to think you have those things because I haven't done a good enough job clarifying what you don't, right? So make sure you ask for the why not. And plan for the follow-up. This is what we talked about in our earlier episodes, making sure that you have a game plan for the follow-up when I see you in 2 weeks, 1 month, when I get the lab results, when I get the image results, when I get the follow, like, make sure you have a plan even for the follow-up. Have a plan for what we're doing right now, and then have a plan for the follow-up when that goes down, right? So I think those are big things. Again, those are 5 things. Know the limits of the risk assessments and the guidelines. Trust your instincts. That's probably should be number 1. Trust your instincts. Build a symptom diary. Shout out for the patients. Ask for the why not list. Hey, why is this not the issue? Because again, you want that level of reassurance, and then more importantly, plan for the follow-up, right? And I think it's big, right? I think it's big, right? Because if you understand that medicine is this, like, beautiful science, but it's not exact 100% of the time, you understand that there's going to be some people who are low risk, right, that have an event. The same way you should understand there's people who are high risk who never have an event. Like, you may be saying, Dr. Pierre, how's this person high risk and nothing ever happens to them? I don't know, right? It just does. And how does this low risk person and the things happen to them? I don't know. It just does, right? Again, medicine, it's a beautiful thing that we do here. But it is something that has to be worked on both sides, right? So that's key, right? And you know me, I love my myths. Get them out of there. Get these excuses. Excuses are tools for the confident. It's here to build monuments of nothing, and nothing leads to nothing lists. Come on, let nothingness, right? Number 1, if my doctor says I'm low risk, I have nothing to worry about. False. X. Get that out of there. If the doctor says I'm low risk, I have nothing to worry about. That's the same thing. Like, my doctor says my labs are normal. We already talked about that. Like, get that out of there. Like, that is not true. All symptoms must fit this textbook approach. If it doesn't fit the textbook approach, it has to be something else. Nope. You can have one thing or 2 things. This happens a lot, especially you'll see studies that talk about how women who typically suffer from cardiovascular disease a little bit more frequently is because their diagnosis and their symptoms are ignored or put to the side and say, oh, no, you're just anxious. You're just this, you're just that. No, you're having a heart attack. I'm having a heart attack and you're telling me I'm anxious. I'm having a heart attack and you're telling me I'm stressed, right? Like this is what some women are dealing with. This is what a lot of minorities are dealing with, right? When they tell the symptoms, and because they're like, yeah, you know what, they're histrionic, they're this, they're that, they completely ignore it. And then the high risk event occurs, right? Like, so then your symptoms, especially as a provider, the symptoms do not necessarily have to fit this textbook approach, because guess what? Right? And I know this is a dirty secret that people don't realize. Most of these research studies, especially, I have a public health degree, right? So a lot of times, one of the best things about my public health degree is that it forced me to be very critical of these studies that happen, right? So one of the things that we typically look at is who is the population in these studies. So you'll be surprised that the population of these studies aren't, what would you say? They're not very, like, there's not a great diversity, right? I know y'all hate the word diversity these days, right? It's not a lot of diversity in these studies, right? And so, yeah, for that one group that filled the study, yeah, these symptoms should be textbook, but it may not fit for the other groups that didn't get to the studies for lots of different reasons. So, and this is a big one. I'll just wait until it gets unbearable, right? Like that. My thing's beeping me. Let me know. Like, Barry, don't wait. I'll just wait till it gets unbearable. No, you will not. No, you will not wait till it gets unbearable. You need to take care of business ASAP. I don't care if you're low risk. I don't care if you had normal labs. If you got symptoms, if your symptom diary is starting to build up, you go get that addressed ASAP. Like that's the key. Like that is the key here, right? So remember, right? If we don't learn anything today, low risk patients can still have problems. Just like normal lab patients can still have problems, right? You are not exempt just because you're considered low risk by your doctor, right? And you as a patient, as the number one person who has to, again, empower yourself for better health, you have to be able to say, you know what, doc, we might want to do some more tests. I got some more questions. I got some more concerns. Why not me? Why not this issue? Why not that issue? I got some more. I got some more things I could tell you about that could probably add to your story that make you believe me a little bit better, right? So understand the level of importance when we're talking about this assessment of being low risk, right? Because again, low risk doesn't mean you're out of the woods. Does not mean you are out of the woods. It just means that based on a classification criteria, you're on the low end of something that may likely happen. Doesn't mean you're out of the woods. Doesn't mean that it can't happen to you. It just means you're on the low end of something happening to you. And I want us as patients, right, to be our advocates, to understand that, like, I'm not out of the woods yet. Like, and because I know I'm not out of the woods, I never have to use my voice, right? I have to track my symptoms. I have to do all the things I need to do to make sure I'm well taken care of in this crazy world of medicine, right? Like it's a beautiful thing. But it's not an exact science, right? As much as we want it to be, it's not exact science. And you still have to be able to kind of recognize when, you know what, something is a little bit different here. Like it's a different approach that I need to take. And if you do so, right, guess what? Life equals health. You have to live longer, right? So again, remember, I'm yours truly, Dr. Barry Pierre, host of Medicine Mondays. Make sure, again, you are subscribed to the channel. Make sure you like this video, right? And share it out to 10 friends. I'm going to see you guys next week.